Tom, could you start broadcasting, please? Thank you.
Okay, we'll make a start then. Can I begin by welcoming everybody to this Adults and Health Scrutiny Review Board meeting. This is first meeting of the year. Obviously, I think according to the previous schedule, we should have met in April and also in June, but because of COVID spreading pretty fast then, I don't think all the arrangements could have been put in place to enable those meetings to happen. Shall we begin by introducing ourselves so we all know who's here? I'll begin with myself. My name is Fareed Hussain. I'm Councillor for Arboretum Ward and also chair of the review board. Who's going to call out the numbers, or I don't know how the system is going to work to enable everybody to introduce themselves in turn.
Would you like me to run through who's actually here? Would that be helpful?
Yes, please. So
Okay.
when you call out the name, if people could introduce themselves at that point.
Okay, Councillor Pegg.
Hello, yes, Councillor Adrian Pegg, Councillor from Muckworth Ward.
Thank you. Councillor Froggatt.
Evening, Councillor Dan Froggatt, Councillor for Muckworth Ward.
Councillor Hussain, we've already met. Councillor Eldrip.
Sorry, Councillor Eldrip's just said she's got to stay on mute. She is on the call, but she won't be able to introduce herself. Thank you.
Thank you. Thanks, Dom. Councillor Cooper.
Hello, I'm Councillor Cooper, Councillor for Chaddersden Ward.
Okay, I'm on to officers now. I've got Pervez Sadiq.
Hello everybody, my name is Pervez Sadiq and I'm the Service Director for Adult Social Care Services.
And Robin Jewis.
Good evening, I'm Robin Jewis, I'm the Acting Director of Public Health.
Thank you, Robin. Moving on to the NHS, I've got Zara Jones.
Hello, I'm Zara Jones. I'm our planning lead for Joined Up Care Derbyshire and also Exec Director of Commissioning for Derby and Derbyshire CCG.
Vicky Taylor. She appears to be mute. We'll come back to Vicky. Stephen Lloyd.
Yes, Dr. Steve Lloyd, Exec Medical Director, Derby and Derbyshire CCG.
Thank you. I'm Lindsay Stevens, I'm from Democratic Services, and together with me on the call are my two colleagues, Karen Squires and Dominic Monaghan. I think that's everybody. I'll go back to Vicky to see. Vicky, can you hear us? Are you able to? I'm not getting a response from Vicky Taylor. So sorry.
Okay, sorry.
Councillor Hussain, do you want to go ahead now?
Yes, yeah. We'll get on to agenda proper. The first item is apologies. Have we got any apologies?
No, I haven't received any apologies, Councillor Hussain.
The second item is late items to be introduced by the chair. I do not have any.
Right.
And the third item is declaration of interest. Has anybody got to declare any interest? If not, then we move on to item 4, which is minutes of the meeting held on 4th of February 2020. I know it's been quite some time and I don't know whether the constitution of this review board is, well, obviously there's been changes, but I don't know whether anybody can think back to February and perhaps propose that these minutes, because I wasn't actually on the board in the previous year. I wasn't at the meeting. So if somebody's got a recollection of what was discussed, the minutes are actually in your papers, and if you've had a chance to look through it, can you move that these minutes are correct? Anybody who was there at the last meeting? If not, we can move them as read, approve them as read, and then we go through the matters arising.
Move them as read, Chair.
Okay, have we got a seconder? No? I'll second them then. Although I wasn't at the last meeting, I don't know technically whether I can do that or not.
I should imagine it's okay. Yeah, yeah, that's fine.
All right. I'll go through the minutes page by page. Are there any matters arising on page 1? Page 2? Page 3? Page 4? Page 5? Page 6? Page 7? And page 8. If you've got the papers in front of you, because I don't know with this arrangement whether people are able to see the minutes or whether they've had paper copies. But there are some items which appear to be outstanding from the meeting that was held back in February. And the board had requested some report backs for the April meeting, which obviously didn't take place. And neither did the meeting in June take place. So this is the first meeting since. The items which were asked to be reported back, the first one was the board requested that winter pressure update report to be brought back to the meeting on 21st of April 2020. Obviously, there is little point perhaps we can still, the board can decide whether that is still relevant and whether we need to see it at our next meeting, or whether people feel by the time the next meeting takes place, half the winter will have gone anyway. But if you want to have a sight of that report, then it can be circulated. What's the view, team?
Chair?
Yeah.
I'd like an update on the Wellside report, please, when, of course, they were supposed to be coming back, weren't they, on how the one surgery was operating.
Oh, yeah, that's the Horizon Healthcare branch.
That's it, Horizon. I was there. I was close.
That's right. Yeah, that was also listed, and a report back was actually requested. Can we have that at the next meeting, please?
Yep, sure.
Can you request that?
Yes.
And the third item was pharmacy services at UHBD, Pride Pharmacy, key performance. A report back on that was also requested in the February's meeting. So if we could have a report back to see how things have settled down with the new arrangements and whether any problems are being encountered.
Yep.
Because there's a change of provider.
Okay.
So if you could get a report to the next meeting.
Yes.
And then there was another item which is access to surgeries update. I don't know. That is something which the previous board might have discussed, but it looks as if that item is still outstanding. So if you could get some information on that.
Yes, I'll get that
That's
sorted.
probably one of the reviews that you carried out.
Yeah.
Or something. Yeah.
Yes. I'll get that sorted for the next meeting.
That's about it then. Okay. If that's okay, then we can move on to item 5. And I think we've got Zara and Stephen to present this report. Now, obviously, quite a lot has changed because obviously everybody was hoping that by this time we may be in a position where we've overcome or somewhat overcome COVID-related issues, and things might be returning back to normal as they were before the onset. But obviously that's not happening because it's been a big upset. But anyway, Zara and Steve, if you could take us through the issues and perhaps comment on how the upsurge might affect your plans. Over to you then.
Thank you very much, Sarah. I'll just try and share some slides if that's okay, if you just bear with me for 1 second.
Okay.
It just says it's loading, so hopefully it's coming on the screen in a second. Apologies, it seems to be taking a while. I'm assuming there's no other way of me sharing it with anyone to put it on the screen.
You could try emailing it across to me, and I could try sharing if this doesn't work.
Okay. Yeah, it's not allowing me to do it. It's saying there's some connectivity issues or something. So I can apologies. I don't use Skype very often, so I'm trying to work out whether by sharing my screen that will show it, but I don't know what that will show. I can try that. Has that come up at all?
Yes.
Yeah, we've got it now.
Excellent. Thank you. Apologies for that. So that's a relief. So I'll just I'll take you through a few slides, just I suppose setting out a bit about our plan against sort of the NHS national ask that's been made of us, where we think we are, some of the challenges, some of the risks, and I wanted just particularly to update you on some particular aspects of our plan. So we're going to do a bit of a focus on primary care and also health inequalities. And then finally, I think the committee might have asked for some detail around a new national initiative called 111 First. And I just wanted to give you a few headlines on that and what that means for Derbyshire. So can I just check that the next slide has come up and that's working okay?
Yeah.
Context, yeah.
Great, I'll keep going, thank you. So hopefully you can see that. Okay, I'll just make it a little bit bigger. So just in terms of the context then, and I think some information has been shared with you in advance, which is effectively the national letter that we received from the Chief Executive and Chief Operating Officer of the of NHS England at the end of July, and this included a number of detailed objectives that we needed to meet, but broadly came under three key categories. So something around the ability to restore levels of services which unfortunately we needed to either suspend or slow down the activity levels in response to that first wave of COVID that we saw sort of starting in sort of March and April time, and using the opportunity, particularly ahead of winter as we're now entering now, to try and restore as much of that activity as possible. And I'll go into that detail in a few minutes' time. Also, equally, that preparation for winter. And as we are now unfortunately seeing that resurgence of COVID, and making sure we have the most robust plan to deal with what might be seen as normal winter pressures, but also the added complexity and impact of increased levels of COVID, both in the community and in our hospital sector. And then also sort of bringing those things together, being able to really clearly articulate as a system where we might have learned some lessons from the first wave of COVID. And whilst no one would wish to be in this pandemic situation, there have been a lot of beneficial changes that we have seen working with our partners across the NHS and social care, and with our sort of multi-agency approach to sort of managing the crisis. There are some key things that we've learned from that, and we'd be keen to hold on to and to work through as we go forward. So those were kind of the three key themes really that we needed to work through. I just then wanted to focus a bit on some of the specific requirements that were asked of us in the NHS plan to respond to those things and where we are now. So I'm not going to read through all of the detail here, but just to pick out a few of the highlights. So within primary and community care, some particular challenges that we faced around some backlogs of activity where, because of the impact of COVID, some of those activities weren't carried out at the levels previously. So things like childhood immunisations, screening, and also some particular services that we were needing to really bolster and build up again in terms of crisis response, supporting people in care homes, and also particular things around supporting discharges from our acute hospitals and continuing healthcare for individuals requiring ongoing support. So a number of things set out in the national letter, and obviously different parts of the country were facing different challenges against some of those things. But what we've been able to confirm from a Derbyshire perspective, and this is outlined on the right hand side of the slide, is our commitments within our phase 3 plan, as we call it, to restore things and bring back some normality to some of those really important areas. And across all those things that I've just read out, we set out a really clear and robust plan for how we would ensure those things happened and that we were restoring those levels of activity. Specifically in the sort of challenge of our winter plan as well, a number of key things which we needed to do and we have been planning for since we had that communication over the summer. So something very much around our bed capacity and making sure we sustained as much of that as possible, and that importantly helps, and I'll come on to this, our elective care programme and making sure those people on a waiting list, particularly those who have been waiting a long period of time, that we had plans to have enough capacity to deal with those important issues. Also, in order to prepare adequately for winter, as we always do, but an expanded programme this year around flu vaccination, and Steve is leading a lot of that work in the system, may well wish to comment on that later. The 111 first offer, which I'm going to come back to just to explain what that is and how that's going to help us through winter, and also some key things working with our ambulance service and also a discharge process as well to really help our flow as a system in terms of responding to demand, particularly on our acute hospitals. So we've also been able to confirm against all of those really challenging things a positive position as well. So in terms of our beds and our capacity, particularly within our acute trusts, we've been fortunate to secure some capital monies so we can expand some of our emergency department facilities to make sure we can cope with increasing demand over winter, but also knowing that our capacity is constrained because of social distancing requirements and other requirements linked to COVID, and making sure we have as much space as possible to see and treat people. And then the other things around sort of our community capacity, the flu programme, etc. We've got some really clear plans as to how we will manage those things. They won't be easy. I think a theme of this presentation is that there are lots of risks involved, but we know what the risks are and how best to mitigate those as they come along. And a little bit sort of headlines on some of the other areas. So I've talked about our elective, our planned care, our waiting lists for people awaiting surgery and treatment. So a number of key performance indicators that were set for us, and we have found this extremely challenging in Derbyshire. And we don't, whilst we're doing everything we can, we don't anticipate being able to fully meet some of these restoration targets to get back to sort of the levels of pre-COVID activity that we've seen for a number of our sort of procedures and treatments that we do need to undertake electively. A lot of that is driven by our clinical prioritisation process that we have been following very consistently as a system. So looking at those patients with most priority in terms of needing to more urgently be treated, and prioritising those patients first, following very clear Royal College guidelines as to how we classify those patients that fit into different categories. Now, whilst we think, and that's the right thing to do, and we need to make sure that those people who need urgent treatment are seen quickly, unfortunately, that does have a knock-on impact on those who might not be classified as urgent as some other patients, but are therefore sort of waiting longer on our waiting lists to be treated. And we're seeing that impact already now, and we predict that is going to be difficult over the next few months, and certainly through winter, where we're seeing more longer waiting patients, and we are working very carefully with our sort of providers and our partners across the system to really understand the impact of that, and doing our best to really support those individuals, even if at this current time we can't build enough capacity to treat them now as we'd like to. I'm sure we'll pick that up in a conversation later, as it's a key risk and concern for us as a system. On the cancer side of things, and I can show you a couple of charts in a few minutes just to show you some of the trends that we saw, and it's quite a worrying time when we went into lockdown earlier in the year, and saw a real drop off in terms of numbers of referrals coming through from primary care into secondary care, in particular on our 2-week cancer pathway, which is often where a lot of cancer cases are picked up through that pathway. And we have been working incredibly hard as a system to increase those referrals. Some of that's obviously confidence of patients to access healthcare and feel able to go to their GP and to be referred into secondary care, but we can see a real improvement in that. So our plans do set out sort of meeting the targets that were set in the phase 3 letter over the summer, and we're making some really positive strides on that. The key obviously as we go into winter is maintaining that and really doing everything we can, as we do through all winters, to be fair, to really help prioritise our cancer capacity to keep treating patients in a timely manner. And then equally, in terms of diagnostic tests, this often has an impact on cancer and planned care procedures as well. We've had some particular challenges in our endoscopy position, which isn't at the level where we want it to be due to some capacity constraints. However, we are seeing levels of restoration picking up now, and we expect to probably get to about 80–85% of the pre-COVID activity levels that we've seen. And then the last sort of summary slide around mental health, firstly, and learning disabilities and autism, really important part of our overall sort of joined up care plan pre-COVID, and a number of those priorities which were there before obviously remain. We have seen some impact in mental health, I think particularly for interventions which often do need to be done face to face, and the inability to sometimes do that, particularly as we went into the national lockdown, and some of the implications of that have been felt in some of the activity levels we've seen. But what you can see here is a number of commitments to improve some of those things, and I'll just pick out a couple. So for example, in the community, our IAP services, so where improving access to psychological therapies, to where people often come in for support with particular mental health issues, particularly before they exacerbate further. We did see activity levels drop off for the reasons I've described, but we're now seeing pretty much back to pre-COVID levels, and actually we anticipate that those activity levels will increase further as the weeks and months go on. We've also done a lot of targeted work around crisis support for mental health, as well as a key part of the plan and the restoration response that we need to deliver. We've got 24/7 helpline in place, and we've been doing lots of work on that specifically with the system to make sure that sort of access remains. So lots of important things going on, both in terms of, so it's from a more preventative and early intervention stage, as well as a crisis stage as well for those individuals who need our support. And then health inequalities, I've got a few slides on that specifically, so I will come back to that. But I suppose the point to make here is that we've obviously been concerned as a Derbyshire system around our health inequalities and some of the inequalities in different parts of the patch that we operate within, through some of the impacts of COVID, some of the operational pressures we faced. Our concern is any widening gaps in health inequalities there, and how we proactively plan to deal with those and understand what those are, and make sure we, as far as possible, meet the needs of those individuals. I'll keep going. Please do ask obviously any questions as we go, if there's anything you wanted to come in on, but I just wanted to pick up specifically around general practice, and Steve may well want to also pick up on some points on this as well, but I just wanted to focus in on a particular sector just to give a feel for actually what's happened over the last few months and where we are now. So I'm sure colleagues are aware that general practice had to fairly rapidly, it felt, almost overnight transform from being a predominantly sort of, you know, a face-to-face sort of service for patients, often their first point of call within the NHS, and being able to do sort of online telephone and other interventions, which clearly already happened, but in a much bigger scale, and almost flipping the face-to-face to that sort of virtual types of appointments. And general practice worked incredibly hard to make sure that we had hubs set up, also specifically those prioritising those at risk, those who at risk or potentially had COVID as well, in order to help in terms of infection prevention and control, and particular support to those vulnerable groups, whether it was sort of people needing home visits, those in care homes, and so lots of things to very quickly do. And I think, and I know Steve would say this as well, I think broadly very successful in terms of being able to make sure that patients had really good access to primary care at a time when things were incredibly difficult, and obviously the public had great anxieties about accessing healthcare. I'm going to skip forward just a couple of slides just for time purposes, but just a few stats here really. So in terms of the sort of face-to-face appointments that I've referenced, so sort of a percentage here, so 55% face-to-face appointments now, which is fewer than what we had last year, which was around 82%. But what we've actually seen is the telephone and online appointments going up 2.5-fold. So you can really see that sort of flip in terms of the types of appointments we're offering. It's really important also, though, to mention, and this particularly comes in when we think about more vulnerable groups and health inequalities, that face-to-face appointments are there available for those who want them, who need them. So it's not saying that we're just operating in that virtual world, but we are seeing the efficiency of working in that way and how we might hold on to that going forward, but importantly making sure those who can't access some of the online ways of working or just need to be seen face to face, clearly that is there available for people. So we're seeing that real switch, and also in terms of access generally, it's obviously very high always on the primary care agenda in terms of appointments offered on the day, or at least within a day of being requested, and we're seeing an improvement of about 10% in terms of those sort of quick available appointments, which again I think is really positive, particularly when we think about some of the constraints facing primary care at the moment. I'm just going to again just flip forward a few slides just so I don't get lost for time. So I wanted then to go on to health inequalities, if I may, and obviously we've got Robin in the meeting this evening, who is our system lead for our inequalities agenda, and we've got a health inequalities group that Robin chairs and has been set up, and it sits very sort of clearly within our infrastructure in terms of Joined Up Care Derbyshire, but also the wider LRF as well, and that multi-agency approach to managing the current position that we're in. And so I just wanted to give a couple of headlines really around our arrangements there. So we've got that really sort of strong partnership approach, as I've said, and if you can see this, apologies, it might be a bit small, but you can see our sort of health inequalities group sits here. It feeds into a wider health and welfare group, which looks at a range of short and longer term health outcomes. So we've got it make sure that our health inequalities agenda is front and centre to the outcomes we're trying to deliver. And it also importantly links into our sort of regular and sort of routine leadership conversations that we have around particular escalation issues. So we're not just thinking of health inequalities as medium to longer term things that we need to enact. We're also linking that very carefully with the here and now and what we need to do to progress certain things. So so that's just to sort of give you a bit of a feel for where it sits in our system working. Apologies, a bit of a busy slide, but just some important prompts for me really to mention to you. So got a particular focus on prevention and sort of self-care, self-management, which the health inequality group is taking forward, covering all sorts of things, but for example a particular focus on childhood obesity and where we think those trends might be over time, and looking at how we might reinvigorate that as a particular priority. We've also got a very clear approach to what we call population health management, so looking across the board in terms of the things that drive the population's health and making sure those things again link very clearly and in an evidence-based way into understanding what inequalities our population face and how best we target those things. And equally we're looking from a sort of a system development side more broadly, looking at, for example, our BAME communities. How do we best communicate with individuals from different cultural backgrounds? And again, linking that into where we see particular inequality risks linked to people's health, things around long-term conditions, obviously things like obesity, smoking, other risk factors, and making sure we've got a really comprehensive plan, not to just deal with those in terms of the work we've been doing previously, but also obviously those added impacts of COVID and some of the responses to COVID we're needing to enact. But also the challenges are there and very real for addressing our inequalities. Clearly, we're looking like we're going into that second wave of COVID, so our plans are only as good as they are now, and we need to keep adapting those and learning and understanding what the needs of the population are and how they might change. Equally, also in terms of that sort of next 6 to 12 months picture, we clearly know that there's lots of things going on in society at the moment, particularly around the economy and the risks for individuals and the impact those things will have on people's health. So we need to keep looking at what the medium and longer term impacts might be and plan for those accordingly. And then just to come back to the sort of planned care side of things as well, where it sort of talked about waiting lists and our concerns around long waiters for treatments because of our clinical prioritisation processes. Clearly, we are going to have unidentified needs in some parts of our population where people might not be accessing healthcare currently or currently having interventions. So we really need to work through the impact of those things and where our capacity is constrained, what impact that's going to have over the next few months and beyond. So if I'm okay, just keep going for a few more minutes. There was just a couple of slides probably to pick out here in terms of what some of the activity looks like. So I'm just going to pick out this one in particular because I talked about cancer earlier. So you can see this is about the referrals into cancer, and you can see this was that real area of concern as we'd gone into lockdown, sort of the early stages of that in the first sort of a couple of months really, and we got to a real low point around May time where we weren't seeing this, and this is all the different tumour sites, those levels of referrals coming through at all. But as you can see, as we went into the summer, that was certainly picking up, and we're getting back to the levels where we need to be now. And then equally also on the actual cancer waiting time. So when people have been sort of through that first part of the referral process, they're now on that waiting list. There's a really important target around 62 days of referral to treatment. And we can see the positive impacts of these bars getting lower in terms of numbers waiting over that time period, and that's really come down. This is towards the end of September, this data. So that's for our Chesterfield acute hospital, and then for Derby and Burton you can also see that equal sort of that bulge here, which was a real concern, and that improving picture as well. The elective position is that concern though, and we can unfortunately see this growing picture of patients who on this particular chart have waited over a year, and we're working actively to see how we support those patients as they're waiting for their treatment. Finally, the next bit, as I say, I've skipped through a few things just because I don't want to sort of talk for too long, but was just around the 111 First initiative, because I think you'd asked for a specific update on that. So this is very much an initiative to help reduce demand into our emergency departments, where actually those patients who can safely access 111 for signposting or appointments to be booked into either the emergency department itself or into primary care or our urgent treatment centres, for example, that happens first, rather than patients sort of walking into the emergency department and needing to be dealt with at a time when clearly, as winter picks up, it can often be quite busy, and we've got the added issue around capacity with social distancing and those sorts of things. So it's very much an initiative to help reduce the numbers of sort of footfall into our emergency departments. Clearly, we need to make sure the messaging is really clear, and there's national sort of comms plans around that, but obviously equally within Derbyshire we need to make sure that patients know how to access this sort of new initiative and that they're not confused by the different entry points. There needs to be that single entry point. We're working very closely obviously with our 111 provider as well to make sure they've got the capacity, because there'll be an increased requirement and demand on their services to make sure that they can service this particular service, this initiative, and also working with general practice as well, in terms of making sure that we can make sure appointments are available if that's the appropriate place, but also making sure that the capacity in primary care is sufficient as well. And lots of things around the technology, making sure patients can be booked into the emergency department for particular time slots or other areas as is appropriate for that particular patient. We are aiming initially to transfer about 20% of those patients who are walk-ins, as opposed to obviously arrivals by ambulance or anything like that. That would clearly continue as normal, but we've been doing some local modelling to see how many per day we should be targeting, and then we'll be doing some learning and evaluation, and then trying to build up the picture from there. And the timelines very much are now in terms of sort of getting that finalised and sort of going live towards the end of this month. We'll do that bit of evaluation piece and make sure that the sort of comms messaging, both locally and nationally, are really helping us to pick up the ability to increase, hopefully, that initiative and help direct sort of walk-ins to emergency departments to other more appropriate settings as we can. So I'm probably going to pause there, Chair. I hope that was helpful. Obviously, very happy to take any questions. I've got Steve and Vicky with me as well, who may well wish to come in on any particular points. Thank you.
Thank you very much, Zara. Does anyone have any questions? I can't see any names on the bubble. Oh, Lisa. Yes, please go ahead and ask the question.
Thanks, Chair. Sorry, it might be a bit loud in the background. Just a couple of questions about the GPs, if it's the right place to ask. Just a couple of things. Firstly, kind of what monitoring is in place or is being put in place to kind of look at the quality and the impact of the change in terms of, you know, assessments and appointments being done online or over the phone, to ensure that, you know, that GPs are able to pick up issues and that people are satisfied that they're getting kind of that quality service in the same way that they would do with a face-to-face appointment. That's the first thing. And also just kind of, again, and it might not be the right place to ask it, but what the advice is in general to kind of GP surgeries in terms of whether or not they should be operating face-to-face appointments, how that decision is made, who makes that decision, and kind of what, you know, is that left entirely up to each individual GP practice, or is there some guidance around that?
So I'm happy to take that question, just to allow Zara to have a breather. Certainly with regards to general practice, if we just take a step back and just see what happened during the first wave of COVID. The changes to general practice didn't happen on an individual basis. We had in place a primary care leadership group comprising of the primary care network clinical directors that met on a monthly basis. And in many ways, we were in a strong position to meet the challenge of COVID as a healthcare system like Zara's described, but particularly in primary care, because all practices within Derbyshire and Derby City belong to primary care networks, of which there are 5 in Derby. So that forum, the primary care leadership group and the PCN clinical directors, throughout the crisis, we met with these colleagues on a daily basis with representation from all the PCNs, from the Commissioner, and from the local medical committee to look at best practice and what would be the operating model for general practice as a whole, and to incorporate all the technology that could be used to support general practice throughout the crisis. And just as importantly, beyond the first wave, is capturing the positives, because there are positives that came out of this, including greater use of triage systems, telephone, video consultations, online services. And this wasn't left to individual practices just to try and figure it out, as it were. The support we gave digitally to practices were through utilising specific online systems, specific video consultation systems. GP colleagues had formed what's called the GP Alliance to represent general practice as a provider on a Derbyshire footprint. And they very rapidly developed an operating framework for general practice based on national guidance. And that incorporated best practice triage systems, for example, for patients presenting both to general practice through the various modalities. So there is a standard for general practice, if you will, an accepted standard for all practices to adhere to, both individually and as PCNs. And this is the strength and the coming strength of primary care network, is the interconnectivity of general practice and the standardised way of operating going forward. And of course, one of the functions of the Commissioner is to ensure quality and performance in general practice. So one of my teams, in general practice settings, a primary care quality team, and that's been an ongoing mission, if you want to call it that, to ensure quality and performance of all practices in Derbyshire, including the city, meet a standard. And that is an ongoing piece of work that continues and continued throughout the first wave, and will continue going forward in the future. So I hope that answers your questions. And of course, like I say, the quality team do monitor individual practices. We support practices. It's not just about monitoring data. Practices that run into problems, we're there to support them. We have quality visits, which we'll reinstate to support general practice outside of the role of the independent regulator, which is CQC, of course.
Okay. Okay, Lisa, do you want to come back and I've got another question?
Yeah, well, that's great. That's great. Thank you. But I guess my specific concern is that with such a large scale transfer operations, essentially from face-to-face to either online or telephone assessments, that what kind of particular measures have you or are you putting in place to monitor then the quality of the delivery of service, both in terms of the patient experience and the ability of the practitioners to pick up on specific issues, whatever health issues they might be, that may not be the immediate ones that people present with. So that's kind of the first thing. And then I suppose the question that you didn't answer, sorry, was what is the advice now in terms of, what's the advice to GPs now in terms of conducting face-to-face appointments and how those should be conducted, and whether and who makes the decision about whether or not it should be a face-to-face appointment? What's the guidance that you have in place now for practices in Derby and Derbyshire?
So just to answer the last one, the last question first, apologies if I didn't cover that off to start with. There's two elements to this. It's general practice as a provider, it's within the gift of individual clinicians to assess patient requests for face-to-face visits. The constraints of the infection protection measures and the standard operating framework for general practice has been applied both nationally and regionally, and that's the guidance that is used by general practice when dealing with patients on a face-to-face basis or an online basis or a telephone basis.
Okay.
My system froze then. Yeah, so it's not left completely with individual general practice to make up their own rules. There are There are IPC guidelines, there are operating framework guidelines for general practice, which are nationally applied to all practices. And the expectation as GPs, as providers, is to adhere to that guidance. In terms of the triage systems, again, that is like I said before, that's a standard operating framework that operates across Derbyshire practices, but it is within the gift of individual GPs and clinicians to operate within that framework. Does that answer the question? Because I'm not quite sure of what you were trying to get at there, if I may say.
You can speak, Lisa. There's nobody else waiting to come in.
It's all right, it's fine. So I had to go and sort something out with the children, so I may have missed the last couple of minutes of that anyway. Yeah, it's just really just making sure. I think it's a general concern. It's not just a GP concern, but with so many services moving into a different way of doing things, that the monitoring the impact of those services. I think the NHS and across the board, you know, services in the public sector and the private sector have done an amazing job of transferring, you know, away from face-to-face services, and have done that very quickly. But we have to be really, really clear that the impact is the same and that we're getting the same results, and the results are as good. And I think that's where, you know, we need to be really conscious of monitoring it. That's all, Chair.
Yeah, I totally understand what you're saying there, and completely agree with what you're saying. And it's worth holding on to the fact that you know, even in July, when we were restoring services in general practice, around 50% of appointments were face-to-face, and that's even with the new online systems and video consultations and telephone consultations in place. It, in many ways, it's fast-forwarded thinking that existed before pre-COVID, to see patients in the best and most appropriate settings, or to conduct telephone consultations. And this is about appropriateness of consultations, whether they're done through telephone, through online, or through face-to-face, and recognizing that patients do need face-to-face consultations, and that's really important, and factoring that in, and that will not change. And this is about holding clinical risk as well. An awful lot of primary care business can be conducted by telephone or online or by video consultation, but the core bedrock of general practice is face-to-face and remains so, because you cannot hold that clinical risk. And for some people, a face-to-face appointment is the most appropriate thing and needs to happen. And that's the assurance, basically, that we've got, is that that element is taking place. The difficulty in tracking appointments, we've never had that ability to do that before, in terms of what's the offer to the general public in terms of the numbers of appointments. That's always been terribly difficult to understand, and particularly same-day appointments. But again, through the COVID crisis, we've got that ability now to see in more detail what is the offer to the general public in terms of these different modalities of consultation. And that's a powerful thing, and it helps think more about sustainable general practice, how that works across primary care networks. And Zara mentioned the red hubs, and that was specifically for general practice to assess COVID patients, but there is something powerful within that forming up in terms of utilising hubs going forward for community hubs, for locating diagnostics closer to home from secondary care, and for using hubs not just for COVID activity, but for same-day appointments for example, other respiratory illnesses. So it again is that catalyst for change in a positive way, and not in a negative way. and this is my own personal experience as a GP, is that it's released an awful lot of energy and thinking for the benefit of patients, and that's really important, because before it was a real struggle to offer an optimum service at times because of the numbers of face-to-face appointments, when actually we know that an awful lot can be done through other modalities.
Okay, thank you for your very detailed answer. Can I ask a couple of questions? I did raise it initially when I was trying to introduce the item. Will there be an impact from the latest upsurge in COVID cases on your plans in terms of reducing the backlog and the waiting times, etc., and being able to see more patients, which they may not have an urgent case, but nevertheless, they have a desperate need to see if they could get some sort of treatment for whatever the ailment might be. And secondly, if you could comment on the likely long-term impact on inequalities in health. As a result of this disruption, quite a lot of positive stuff that you were perhaps hoping to do to reduce inequalities in health, I'm assuming that they will have had a disruption because of the emergency through COVID coming in. So what is likely to be the long-term impact on health inequalities?
So I'll start the response to that. I think what Zara's outlined is the challenge of restoring services on the back of the first wave, if you want to call it that, of COVID. What we face in terms of challenges going forward in the immediate future are around the usual winter planning, ensuring we've got capacity in the system to meet the usual, in inverted commas, usual winter pressures that we see on an annual basis through flu and flu-like illnesses, for example, and the pressure on acute beds. So that's a challenge in addition to restoring services. Then, of course, we've got the challenge of COVID, which is not going away and will not go away. And then there's the other pressures that we need to factor in. That includes Brexit, that includes potentially delivery of a COVID vaccination program, and the challenge of delivering the flu program to this date. And what is the learning basically from the first wave of COVID, and particularly through the lens of health inequalities? What's it told us? In many ways, it's told us nothing new, but it has sharpened the focus on the need to address health inequalities, because we do see the disparities of outcomes in terms of COVID, and that's age is the greatest disparity, of course, but what else is there that's highlighted through COVID? What's the disproportionate effect? The disproportionate effect is not just on age, but those with long-term conditions, those from ethnic backgrounds, those hard to reach groups in particular. And that throws down the gauntlet in terms of how we approach health inequalities going forward, which Zara outlined in a presentation. And this has given a real catalyst. And this is one of the, in a perverse sort of way, one of the positives that come out of this. It sets a really clear focus on where we need to go, thinking on not on a short-term basis, but on a long-term basis in terms of commissioning services. Not just for the next 12 months, what does it mean for the next 5 years, for the next 10 years, for the next generation, basically? And where do we put our effort now? And it's just turning the dial, if you want, towards a more population health management approach, as opposed to a simple reactive demand-led approach. And what will be the demand in the future if we do nothing? And where do we need to put our emphasis in terms of of prevention in particular, because we will be failing the next generation if we don't do anything on the back of this COVID crisis, for sure. But that broadly, for me, is what COVID has told us. Yes, in terms of the next wave that's coming, and this is the experience, not just in this country, but in Europe, rise in incidence rates. We see that throughout the UK. We're beginning to see that in Derbyshire. The impacts that it will have, like I say, it's a very fine balance between being able to restore services, putting sufficient capacity to meet the usual winter demands, but also ensuring that we've got capacity to meet the COVID challenge, as it will inevitably, and we're beginning to see that lead to increasing hospital admissions, and particularly in those vulnerable age groups that I've mentioned. But the mitigations for all this, and what's the, again, what are the positives? We've learned an awful lot through the first wave about capacity requirements and what we need to have in place. So we've got that. In terms of mitigations, the flu vaccination program that Zara mentioned, this is regionally commissioned and mandated, but we have to coordinate this through the integrated care system. So this program is obviously a recurrent annual program, but the ambition on this is increased this year for sure, in terms of increasing the coverage, if you will, of flu vaccination, because we need that in place, and we need to fast forward it within the constraints that we've got in terms of supply of flu vaccines. And I'm pleased to report that the early signs are that there's an increasing willingness for the general population to take on board flu vaccination and the importance of it. And that's important to get that fast forwarded program in anticipation potentially of a COVID vaccine landing on our doorstep. And part of this, of course, is developing the infrastructure for delivering a COVID vaccine, should that happen.
Thank you, Dr. Lloyd. Can I request that we receive another report in April commenting on waiting times, general impact, because there is an upsurge going on. We don't know where it's going to end up and how much pressure is additional pressure is going to generate on NHS. So if we could have an update in April, I think that's 6 months away, to see where we are, and perhaps outline some I don't know, if you end up taking any new initiatives in between, you could perhaps incorporate, all those aspects in that update then.
Yes, certainly, Chair, and that would be an appropriate time at the end of winter as a stop date for the system. Like I say, it's a very fine balance between capacity to manage the restored services and continue the elective activity, and particularly the priority areas around cancer and 2-week waits against the acute bed requirements that normal winter planning throws at us, but added into that factor the COVID situation as well. So April would be a very appropriate time for informing city colleagues on where we are basically post-winter.
Thank you very much. Nobody's got any other questions. So can I just thank you and Zara for your detailed presentation and your comments and your answers. Thank you very much. Hope to see you again in April, if not before.
Thank you, Chair.
Thank you. Thank you.
Thank you. Okay, we move on to item 6, and I think Robin, you're going to take us through this item.
Thank you. Yes, I'm just going to again attempt to share the presentation. So you bear with me a second. Has that come up? Are you able to see that?
Yeah, I can see you. Just see the presentation.
Has the presentation come up?
Yep.
Yes, I've got it.
Yep, wonderful. So I think, as you said, when there were original discussions around having this discussion, it was thinking about the consequences of something that was perhaps past, but we're clearly not in that position. And so what I've done, we don't have a great deal of data behind this, but we have some reflections and intelligence from the community. So what I've done is pulled some thoughts together, and it'd be really helpful to have a discussion around what the emerging feelings are from the community around the impact. So a brief reflection on the first wave, and just to explain the position we were in during that time. Summary of where we are as far as the health of the population is, and what we understand around the health of the population, and then a reflection on winter, which will follow on as well from Zara and Steve's presentation. So within the first wave, we had a very nationally coordinated response. There was a national response driven very much by Public Health England, and decisions that were made that didn't really involve us as a local area. So there wasn't a great deal of testing within the community. Testing was carried out when individuals were admitted to hospital, which meant that we weren't aware, as we are now, of the virus circulating and where any particular hotspots of the virus were. There was a decision relatively early on to end the contact tracing programme that was in place, and partly because of testing capacity and partly because of the capacity of Public Health England in order to do that contact tracing, because it did become incredibly onerous for them as a team. There was a lack of data sharing with us in local areas, and you will remember there was a lot of national debate about that, and a real challenge for us, and a personal challenge for me, in that I could see the numbers of cases in the city rising, but was unable to identify where in the city those individuals were or who they were. We know that there was a really significant impact on some city communities, and I think this is where the discussion around the health inequalities comes in, because we do know that BAME populations in the city, particularly the Pakistani community, were significantly impacted really early on within the pandemic. But we also know, as followed the national trends, that people who were older and men were also significantly more impacted. And then we moved to the national lockdown measures, which brought in a very uniform response across the country, and it clearly had a really significant impact on the spread of the virus and the consequences of the virus as well. And during the first wave, during that challenging period where it was difficult to see what was happening within the community, what we did was we worked with Derby Hospital, who were incredibly helpful in sharing the information that they had on the cases that tested positive that were admitted to hospital. So we were able to look at that data and understand at least that tip of the iceberg that was ending up in hospital and which communities were being most affected by that. We were also delivering a great deal of communication and sharing of the national messages. And really at that point, the national messages were the key thing for us, because as we didn't have that understanding about which local communities were being most impacted, it was really challenging to then target those messages. And we also were working really hard with partners to respond, so both through the Local Resilience Forum from a partnership emergency planning response, but also with NHS partners that Pervez and I were involved in working very closely with. So then just to move on around a reflection on the impact that's happened so far with the community. And there's obviously the direct health impacts of COVID, and obviously we know about the deaths from COVID, and within the city to date we've had 324 individuals in the city that we've lost to coronavirus. Along with that, there's also emerging evidence of a condition called long COVID that you may have heard of, which is a really challenging recovery period and can happen to very young individuals as well as older individuals as well, and is almost a post-viral fatigue, as we may see with other conditions as well. And there's also obviously the mental health impacts of bereavement as well within our communities. But indirectly, there's been significant impacts on mental health as far as isolation are concerned, the management of pre-existing conditions, and we were discussing earlier around the perhaps reluctance of individuals to go forward to present with conditions or to raise issues, perhaps because they were concerned about the capacity within the NHS, perhaps because they were concerned about contracting the virus and that it may be a high-risk setting to actually visit the hospital or the GP. We've also discussed about those waiting for planned procedures, and the NHS have been working incredibly hard to try and get those waiting lists down and to get activity back to normal. But the reality is there's a lag in those waiting lists from the period of time when activity wasn't being undertaken. And then on top of that, even managing to get to 90 or 95% of activity is still not catching up. There's still an accumulation of cases, and it is an incredible challenge as we go forward into winter as well around how to manage that situation. Screening programs were still available, but people, particularly with cervical screening, it was available within GP practices, but people may have been reluctant to go forward for it, as discussed. And also for some of the other screening programs, such as bowel screening, there was a challenge in providing the endoscopist for that. And so there has been an accumulation of waits across those screening programs, and there's a program being undertaken nationally as well as across Derbyshire to pick up and to catch up with that work. From a lifestyle perspective, we still can't see the impact from a data perspective, but we have had reports of increased access of smoking cessation services. There's been a really strong message that stopping smoking, if you're a smoker, is a really positive thing to do to reduce the impact of COVID. And that does appear to have been a driver for bringing some people forward to stop smoking. But we wait to see on the national data as to what impact that's had. From an obesity perspective, we're not expecting such a positive response. We are awaiting currently the child weight measurement programme, which will be carried out in schools. And it is a reality that children have been at home. Those that had a poor diet previously will probably have continued to have that poor diet. There's likelihood that they will have had less physical activity because they haven't been at school and out and about over this period. And so there is a real risk that obesity from children up to adults will also have increased over this time. Clearly, it's not just the direct health effects, it's also the indirect health effects. So thinking about the financial consequences of this period and thinking about the individuals who have been on furlough and reduced income or perhaps will be being made redundant over this period, and the impact that we know that a loss of income will have on their health, including their mental health, but also their physical health. We have had some good news on children's vaccinations in that parents have been willing to take their children forward for vaccination, and the performance for the childhood vaccination programme is relatively similar to last year, which I think is a huge credit and success. I won't dwell on the health services section. We have discussed most of those issues around virtual services and the reprioritisation and restoration of services. But just to mention that health inequalities work that we're doing includes working around the waiting lists and whether there are interventions we can put in place to help those people on the waiting lists to perhaps live with their conditions more successfully, perhaps assist them in reducing weight while they're waiting for some of their procedures. And we're currently looking at a bid into NHS England around supporting that work. So just thinking about the winter to come and reflecting on what we're seeing, we're obviously seeing a rise in cases of COVID, and that's in the city as well as across the country. And we anticipate that will continue. There's a number of drivers for the increase in the virus, including our increased mixing that's happening, the return of schools. But along with that, there is just the seasonality of winter, which respiratory viruses are always happier at this time of year and always more enabled to spread. And we know that the positive impact of being outside is not available to us across the winter months. We're also well aware of the other winter pressures that are going to strike with the other respiratory viruses that will be circulating, and we saw that when the schools returned and the children all came down with their colds, but also the cold weather, and just being aware that some of those individuals who may have been reluctant to go forward for their long-term condition care may be more vulnerable then to the cold over this winter, so perhaps due to their respiratory or cardiovascular conditions. There is a huge mental health impact of isolation and of staying at home that has been experienced over this time. And I think the impact of that can't be underestimated over the winter period as we become moving into the darker periods. And also there's festivals coming up, Diwali and Christmas, that will not be celebrated in ways that they have in previous years, and that will be incredibly challenging to some people. There's building pressures on services. We are looking to try and maintain as much as possible, as well as responding to the increase in COVID, and that is a huge challenge and is a particular challenge to us in public health as well, because although there was a frustration in the first wave that we knew very little about what was going on, there was also very limited things that we could actually do about that. But now we have a huge amount of information that has been shared with us, and so there is a huge amount that we as a public health team can do. But that does come then with pressures on the team and challenges around our workload. And then we've also got the changes to the national structures. So Public Health England is being disbanded, but has been a huge centre of support during this period, and the development of the other agencies nationally. They're still very much in development. There's still uncertainty as to where some of those other public health activities that were undertaken by Public Health England will sit, and that includes the oversight of the screening and immunisation programmes as well, which is really key at the moment of restoration as well. So as far as our actions locally, you will have seen that we've got our city-specific communications campaign, which will be rolled out shortly across the district centres, and this enables us to share those public health messages about reducing the risk of contracting the virus, but enables us to also add other messages into that as we move into the winter period around keeping healthy across the winter. We're working to improve access to testing, and we are well progressed now with Morliston Day Centre and the opening of that as a testing site. And we've got a couple of other centres in the city that we're working with Deloitte and Department of Health and Social Care to enable some other local testing sites as well. And this will mean that individuals who don't have access to a car can book into those sites and can walk for their test. We've also established a city-specific response now, so we have stood up our incident management team for the city, which is bringing together all of our local stakeholders, including the university and the police, to look at what's happening with the rates of the virus within the city, to look at any specific areas of concern, and to enable us to have a very localised response. We're continuing to work across the system as we have been, so through Joined Up Care Derbyshire, and specifically with the NHS and also with the Local Resilience Forum as well. The Health Inequalities workstream has been mentioned, and as I said, we're specifically looking at how we can manage and assist the individuals on the waiting list at the moment, and also assisting with the prioritisation of services as well across the system. So that's a summary and reflection of where we are. So I'm very happy to take any questions.
Thank you, Robbie. Can I ask the first question then, because I haven't got anybody else lining up to ask a question. Are there any projections or estimates in terms of when we might hit the peak with this latest upsurge? and what that peak might look like?
So there are various pieces of work and modelling that have been done. And I think on a general theme, we're expecting the rate to increase more slowly than last time. We're expecting the R number to be lower than it was previously, partly because of all of the measures that we have in place that do help to reduce the spread of the virus. But it's really challenging to know when that peak will come and how large it will be, because it is interdependent with what happens around us across the country, but also with what measures the government bring into place. So we know in April that the modelling and planning assumptions that we used then, there was a significant impact on that from having the stay-at-home message. So we know that what's done nationally and those measures can have a real impact on what happens locally. Locally, we can have an impact, but it is more limited because the number of things we can do locally are just that bit more limited than the national measures.
In terms of the R rate, where are we? We are apparently above 1, but how significantly above 1? Do you know what the situation looks like locally for us in Derby?
So we look at the R rate on a much greater footprint, partly because there's a lot of variability and statistical variation if we're looking at it on a small area. If Steve is still with us, I'm sure he's up to date on what the latest R rate is. But the last time I saw it, it was around 1.2 to 1.4 for the R rate. So, Steve, are you there?
Yeah, absolutely. So, as Robin suggests, the R rate, the R value is probably a poorer estimate of local incidence. It's more use on a regional footprint. Currently, the UK R rate is between 1.2 and 1.5, and that's reflected in the Midlands position as well. The same. You've got to keep hold of that R rate, but actually use the growth rate of the infection alongside that, and the growth rate is the daily estimate of the, as it suggests, the growth of the pandemic. That's currently in a positive 4 to 8%, and that's on a regional footprint. And what we have to triangulate downwards is what's the incidence on a local footprint. That's far more informative in many ways than trying to estimate an R value on a local footprint. But nonetheless, it's a measure. And nonetheless, if the R rate is above 1 and the growth rate is positive as opposed to negative, it tells you that that epidemic is continuing to spread. And if you look at where we were in terms of the first wave before the national lockdown, the R rate was probably above 2. And what we saw dramatically with the lockdown was the impact on the R rate, which immediately dropped it down below 1 and held that epidemic in check at that point in time. The difficulty, of course, is maintaining that R number below 1 and keeping the infection rate and the infection growth under control. This is always going to be the fine balance in terms of the economic well-being of our people and the other health and well-being of our people in terms of mental health, like Robin's alluded to, going forward, until we get what I would describe as the ultimate mitigation, which is a COVID vaccine. So it's going to be a very challenging phase ahead of us, as colleagues are aware from the media. And in terms of the impacts of the tier system that's been introduced, will it be robust enough to drive down local incidence to reasonable levels going forward? And what would be the impact on that, on the health and well-being of our people? And this isn't uniquely a Derbyshire problem or even a regional problem or a UK problem. It's the dilemma that's faced globally, basically. How do you manage that competing demand about keeping an economy going, but protecting the most vulnerable people within our communities? And there is no easy answer to that.
Sorry, you might or might not know the answer, but say if the R rate is between 1.2 and 1.5, the current numbers that we are seeing per 100,000 population, our infection rate is around about 80 per 100,000. If the current, if the reproduction rate stays the same, then obviously those numbers are going to increase very significantly, aren't they, over say 4 to 6 weeks. And I've got no idea what in a worst case scenario, what those numbers might look like if it continues to grow at the rate it is currently spreading at.
Yeah, so yes, the last report that we issued did have numbers at that level, didn't they? And now we can see there'll be a new report coming out hopefully tomorrow with the updated data from last week. And we can see from that we now gone over 100 per 100,000. So we can see that there's been that level of change within that week. In order to understand the impact of the R value, so if we have an R value of 1.2, that means for every 10 people that they will infect 12 people. And that assumes that we know that everybody who is infected, and we know that the numbers of positive diagnoses we have for the city will not be everybody who is infected. We know that there will be individuals that we can't find. So that's an additional challenge then to us in order to estimate what the rate of change is going to be. There are various modelling tools that are used looking at the different R rates. But there's an expectation between various different modelling tools that we will peak either towards the end of November or towards January, depending on which tool you use and which measures are in place. And I think the Prime Minister's announcements yesterday indicated a change in the approach in instigating tiers of intervention, and also a larger proportion of the country that will be in some level of intervention. But I imagine that greater measures will be needed because we've got greater challenges this time. We know last time that we had the stay-at-home message that was really effective, but also what we had was moving into spring and the impact that spring then has on the spread of respiratory viruses. This year, the measures are being taken as we're moving towards winter, which just adds that extra difficulty. And so we know that if we had exactly the same situation with the numbers and did exactly the same thing as we did last time, in all likelihood, we would have had a worse outcome just purely because it's about winter rather than the spring. I'm not sure if that's helpful. There's a huge degree of uncertainty is what is effectively.
Yeah, I'm just trying to get my head around.
Yes.
And in
But that's very helpful. Thank you.
And in terms of planning assumptions for health system capacity, and I'm talking not just about the acute trust, but throughout the health system, what the approach we use is to look at different R numbers to give us some indication of what capacity needs would be required at various levels of R, and utilising data from public health colleagues is to track what the incidence and the R number is telling us in terms of trajectory, to give us that element of forecasting ability. Nonetheless, it's a limited forecastability because obviously over a 6-month period, it's very difficult to assess what the level of impact and the various tier options would give on the spread of the epidemic.
Thank you very much. There are no more questions from anybody else. Robin, can I ask you to report back in April again, but obviously if there is a significant change, we might ask you to come back at a short notice.
Yes, that's no problem. And I note from it's such a long time, February, but I was at the meeting at February, and I was going to also bring back something about immunisation, which obviously hasn't the strategy hasn't been published, and we haven't moved on with that, but perhaps I could also update on that at the same time. We're expecting some national changes, as I mentioned, in the oversight of the screening and immunisation programme, so I'll be able to build that in as well in April.
Sure. If anything changes, obviously there are 2 meetings between, I think, is there 1 or 2? I can't remember, Lindsay. But obviously, if something emerges unexpectedly and you wanted to draw our attention to it, the meeting in between, you're welcome to bring a paper to it or come to have a chat with us. Not a problem. Thanks very much then. That's end of that item. We'll move on to item 7. And item 7 is work program and topic review. As you're all aware, we always select a topic for in-depth look into, and there are a number of issues which have been under consideration. And there is also Appendix 2. This was inserted in the last month or so because of what happened in our care homes. As you will remember, this wasn't just a Derby issue. Obviously it was a national issue, but we had a huge number of people who were having to go or having to be admitted to hospital. Many of them either contracted COVID in the hospital or they were admitted with COVID and then went back into care homes. And a lot of people died. So there was a major upsurge in deaths regarding people who were residing in care homes nationally. My suggestion is that we ought to take an in-depth look at what was happening at the hospital and what arrangements were being put in place before they were being discharged home, and hopefully make some recommendations after taking a look at the whole issue. But that's my suggestion. But if there are other areas that interest people more, they're welcome to put those ideas forward, and we can have a bit of debate and then hopefully select a topic for further investigation or take a closer look at.
Yeah, give it to him.
Anybody? Can people hear me?
Yeah, we can hear you. We can hear you quite clearly.
Oh, sorry, I'm not getting no response. So I just wondered whether I'm talking to myself.
No, you're all right. We're here.
Okay. If there are no other suggestions, then I suggest that we adopt this as a topic review topic to look at, and then begin to look at some evidence. Is that okay? If I don't hear anything, I will assume people are in agreement.
I'm okay with that, Fareed.
Okay. I've not seen any comments, so I'm assuming people are in agreement. And if everybody is in agreement, then that's what we will do then. We will select that as the topic that we're going to look at. And that is our last item for the evening. And if there are no other comments, then can I thank everybody for their participation and join in the meeting, and have a very good evening.
Thank you, Chair.
Thanks,
Fareed.
Thank you.
Cheers. Bye.